Karthik, it's you.
Sir, one hour. சின்ன மீட்டிங்ல இருக்கேன். உட்காந்துக்கங்க 2 minutesல வந்து நான் பேசுறேன்.
Yes, Karthik.
Shall we start, sir?
Yes, Karthik.
Yes, sir. A very good evening to one and all. There is a Tirukkural which was written 2000 years back, says, கற்றிலனாயினும் கேட்க அஃதொருவர்க்கு ஓர்க்கத்தின் உற்றான் துணை. Let me repeat. கற்றிலனாயினும் கேட்க, which means even if you are not learning by yourself, by hearing from those who have will help you in adversity. Yes, that is the power of listening to such lectures and answers. Welcome to Ask Your Mentor session 9. Today it is going to be a very interesting program with those learned people. Over to Dr. Melita to introduce the moderator and mentors.
Thank you, Karthik sir. Our moderator for the day, Dr. James Anthony Bhagat, completed his undergraduation and master's from Savita Dental College. He is an IDEA certified implantologist and World Clinical Laser Institute trained surgeon. He is associated with various research projects and has many national and international publications to his credit. Currently, he is an associate professor at Adi Parasakti Dental College and Hospital and consultant oral and maxillofacial surgeon at KL Hospital, Chennai. Thank you for joining us today, sir. Now over to Dr. Mrinalini to introduce the mentors for the day.
Thank you, Dr. Melita. The first mentor for session 9 is Professor Saravnan. Dr. Saravnan received his fellowship from the Royal College of Surgeons, England, and from the International Congress of Oral Implantologists, US. He has an experience of over 20 years. He has published numerous literatures of credit, has given guest lectures at various notable forums, and is an AHA certified BLS and ATLS instructor. He is currently affiliated to SRM Katangalathu Dental College as professor. His field of interest covers oral implantology, orthodontic surgery, maxillofacial trauma, pathology, oncology, and reconstruction. We welcome you, sir. He will be covering the topic diagnostic investigations. The second mentor for today is Professor Krishnan. Dr. Krishnan graduated in 2002 from Mahatma Gandhi Postgraduate Institute of Dental Sciences. He is currently affiliated to JIPMA Pondicherry as an additional professor. We welcome you, sir. He will be covering the topic nerve injuries and neuralgia. Over to our moderator, Dr. James Bhagat, to commence the session.
Good evening, everyone. We'll be starting with the session for today. Topic being diagnosis, diagnostic investigations, nerve injuries, and neuralgia. Talking about diagnosis, we know how complex it is because basis of treatment is based on a good sound. It is predominantly important. We'll try to cover to certain questions, whatever been asked for, because diagnosis as such is by itself is vast. We'll try to stick on to the time and then cover whatever is possible for the day. The first question to be discussed is the latest diagnostic tools for cancer detection and Chairside investigations for cancer diagnosis. To start with, we all know that diagnosis starts with a good clinical examination. Whatever the advancements of technologies help us to diagnose certain diseases, still now the gold standard will be a good clinical examination. Further that, from the provisional diagnosis, what we gain from the clinical investigations or clinical examinations, what we do, to validate on the provisional diagnosis, we do certain diagnostic investigations as well. Talking about the latest diagnostics tools, the various Chairside tests for detection of potentially malignant lesions, it starts with vital staining, light-based detection systems, cytological techniques, and histological technique. The gold standard being the histological technique. The problem with diagnosis of oral cancer is early you diagnose cancer, the treatment outcome is better. But most of the instances, the patient do not turn up to you for a histological biopsy or a minimal surgical procedure. If you can catch them early, the prognosis will be better. And there are certain diagnostic tools which can be done on the Chairside for early detection of cancer. Certain latest advancements, certain high-profile latest advancements which are available even today, where even minimal of epithelial change, minimal of dysplastic change can be identified, which cannot be picked up by a naked eyes, but can be identified using these methodology. I would request Saravanan sir to talk about these various Chairside tests for detection of potentially malignant and pre-malignant lesions.
Thank you, Dr. James. At the outset, I'd like to thank AOMSI, Dr. Jimson and Dr. Vinil in particular, and Dr. Karthik and his team for putting out a fantastic show. And I see the number of participants, and I take it that most of them are just going to go for the examination. All the best to all of you. Stay safe and then do your examinations very well. Coming to Dr. James, I mean, he insisted on this particular point. Of course, we are trying to address every question which has been posed by the postgraduates, the exam going postgraduates. However, there is absolutely investigations are important, but it cannot replace a good clinical history and a thorough clinical examination. That stands as the standout point. Now, when it comes to oral cancer, I guess like most of you would have seen a lot of patients when they are coming in itself in stage 3 and stage 4 diseases. If you see a patient who has come with a frank carcinoma in the mouth, you have an everted lesion, which is basically covering the entire buccal mucosa, going on to the retromolar trigone, or the tongue, which is fixed and the patient is drooling, or a fungating growth. You don't need any of the other techniques. You straight away go for a histological technique, which is your incisional biopsy. Now, Dr. James very clearly pointed out the gold standard remains a histological technique, an incisional biopsy. Now, you can never, I mark my words, you can never perform a surgery nor initiate a patient on a chemotherapy or a radiotherapy without a histological evidence. So let's get one thing very clear. When we see a patient who has a frank carcinoma, we don't have any other stuff. We go directly to D, which is histological technique, which is incisional biopsy. More often than not, if you see a very small lesion, because we don't know whether we are dealing it with a malignancy, or if it's a very small lesion, you could possibly do a excisional biopsy. Punch, you have a tissue which you can basically take a bit of it. It's supposed to be slightly more faster. You don't need to suture that. But punch can literally crush also. In inaccessible areas, they use a punch biopsy. But incisional biopsy remains the gold standard when you see a lesion which clinically you think it's cancer. And more often than not, most of the patients, what we see in this part of the world, unfortunately, they come to us with cancer. Now, one thing about it is oral cavity is such an exposed part. Now, uterine cancer, when we talk about women, right? Now, uterine cancer, again, is a common cancer in females. Now, they have come up with a solid plan of they are giving a very good instructions to the patient that over 40, you will have to regularly go for a gynecological checkup and you need to get a periodic pap smear. And they are catching many of the uterine cancers earlier. Cervical cancers in female is extremely common and particularly associated with HPV. Now, oral cancer, if you talk about the worldwide statistics, it's hardly 1 to 4%, depending upon the geography you are in. But in this part of the world, when we are talking about the Indian subcontinent, where the use of tobacco, betel nut, along with alcohol, it's on a very huge rise, we have a huge burden of oral cancer. In fact, some of the statistics give even up to 40% of all cancers which happens is possibly oral cancer, right? At least we are talking about a 15 to 40%, and probably In women after cervical breast, it's oral cancer. In men after lung cancer, I guess it is oral cancer. So we are talking about a huge burden. Now, what we as, like what I say, maxillofacial surgeons in particular, dentists in general, I guess we need to catch them early. Dr. James was insisting on that point. So we are talking about the first, the vital staining, the light-based detection system, and the psychological technique. All these are supposed to be minimally invasive, because you use the word biopsy, our patients get scared. But when we say a smear, a pap smear does not like frighten any female. But the moment you say, I want to do a biopsy, maybe we can frighten them. So we need to start looking at those type of ones, right? So exfoliative cytology, vital tissue staining. Vital tissue staining is a very simple thing. Now, the thing is, you look at our oral mucosa, which has areas which you are not very sure. Now, the moment you talk about a Toluidine blue, which is basically a dye, when you apply it on the mucosa, it stains, and the uptake of that stain in areas of probably what the terminology what Dr. James used was potentially malignant. It could be the pre-malignant was a past terminology. We used to call pre-malignant lesions and pre-malignant states. Now everything has been combined together, and now we call them as a potentially malignant lesions, right? So if you talk about the potentially malignant disorder, when you do this type of Toluidine blue or a Lugol solution, it highlights the area. And if there is a different type of uptake, I think that is a fantastic way to go ahead and then start doing a small biopsy in that one. A similar exfoliative cytology is possible, but like a brush biopsy and all those stuff, like where you can use a scraping type of brush and then do that. However, our oral pathologists need to become more trained in exfoliative cytology. The amount of positives which the general pathologists catch in a pap smear, what we catch on a brush biopsy is not that equivalent. We have not come to that level of sensitivity with those things yet. Now, the tissue fluorescence spectroscopy, they talk about the Whale scope. I'm sure you would have heard this term, Whale scope and other stuff. Now, this is a fantastic tool if you think about it. When we are doing mass screening, we have to become more open to ideas where we have large risk population. Our index of suspicion should increase. There is no point in seeing a patient year in and year out and then seeing that patient with a huge T4 stage 4 disease. We should be able to catch them early. So if we have a better index of suspicion, when we talk about brush biopsy, staining, and immunofluorescence, the tissue fluorescence, all what we are going to do is in a suspicious area, you're going to shine a light and it is going to come up with a different fluorescence depending upon that one. So the chemifluorescence and other stuff, it's an excellent tool when we talk about, what do you say, a screening, a mass screening. However, unfortunately, what we see more often, it's a frank carcinoma. And when you see a frank carcinomatous lesion, you're not going to use a chemifluorescence or thing. You are going to do a incisional biopsy.
Sir, thank you, sir. So one of the question which has been put forward is they feel that the videoscope and all these things are quite expensive. As such, the cost of a videoscope by itself, it is around 25 to 30 lakhs, if I'm not wrong. So in a situation like in India, what would be the best way? I think exfoliative cytology and Toluidine staining, might that be of good help, sir?
It's a good question, Dr. James, but I think at the end of the day, it's very important that the economics is looked at it as a whole, not as just a one-time investment for an institution. Say, for example, I'm just saying now 25 lakhs, it's like a CBCT machine costs about 40 lakhs. Right. And if our organizing or our sort of licensing body, Dental Council of India, comes up with saying on all oral medicine and radiology clinics, you should have a methodology for oral screening, right? For like an institutional, 25 lakhs is nothing. But if you talk about, what do you say, catching even 5 patients early in a year, 5 patients early in a year, you have got that economics right. At the end of the day, we have to talk about the social cost. So a cost of the equipment should not be the one. And saying that, when a new equipment comes in, usually it comes with a very, very high price tag. However, once we start using it more and more, when the technology becomes much important, then what do you say? It becomes much lesser. Now, when you talked about the Toluidine blue, I have seen a couple of places where I was part of a study. It's not easy and it is extremely messy. You have to prepare it, you have to put it literally, and that Toluidine blue stains everywhere, right? The entire area becomes messy. I mean, our own postgrads, like if they mix plaster or alginate, right, they can make a place messy. Put a Toluidine blue, that room will be painted blue forever, right? It is messy. I mean, but it's a fantastic one. When you start preparing it, applying it on the tissue, we know exactly where we stand, particularly when you look at erythroplakic areas, right? So it's a fantastic tool when you see a potentially malignant disorder. When you see that one, that is a fantastic tool. But a cost should not be the only factor, which I say. Brush biopsy is free. Yeah.
Yes, yes, sir. Point well taken, sir. Because as a government takes up the project and makes sure that the public are being screened properly, I think the whole lot of money which has been pumped in for management or treatment of the cancer which has been diagnosed late
Absolutely
will be cut short. So, starting on to the question, sir, till now, diagnosis, clinical examination plays a vital role, and all the optical biopsy or the VisiLight or things like that, or the staining helps in identifying the disease much more earlier. And then recently we are talking about the salivary biomarkers, what they say as the liquid biopsy. Again, quite a costly affair, because identifying the DNA and RNA within the saliva, it is a good tool again, because what they say is the DNA becomes free from the cell due to the cell debris, or because of the apoptosis of the cell within the cancer. What happens is DNA can be identified within the saliva. That is what salivary biomarkers is all about. The interleukins, the tumor necrosis factor, and there are hundreds of these biomarkers in saliva which can be identified. But again, as you said, sir, the cost is one of the predominant factor in this, but it shouldn't be an issue, because government and bigger institutions start with diagnosing cancer early. Nothing better than that.
The point well taken, James. But the only issue about saliva is we have not come to that level of specificity yet. You told that there are hundreds of biomarkers. Unfortunately, most of the kids actually cannot catch everything. So that is like the subsets within the tumor biology is such a complex biology, and we are still at our nascent steps. We have not come to the adult steps yet. So we still have a long way to go before we could start using just the body fluids, using a sort of a biomarker, which is much more reliable. The one thing is, if we start getting saliva as a reliable sample with a very good sensitivity, but more importantly, very good specificity, then we have a big winner, because the patient's acceptance when you're talking about giving a blood sample, a salivary sample, or a urine sample, is they are much more compliant, and you can make this as a much more routine thing. So if we get there, which we are in the process, I believe, if we get there, which has got good sensitivity and importantly, very good specificity, because we don't want to see a lot of false positive. More importantly, we don't want to see a false negative. So if we can get into that level, then yes, saliva can be a thing. Right now, it is in its nascent stage. They are trying it out, but as we rightly say, we have too many biomarkers and it is not sensitive to everything.
Yes. Okay, so we'll just quickly go on to the next question. So the use of new diagnostic techniques in oral maxillofacial surgery. So coming on to this question, again, newer diagnostics, I do not know where to start with the newer diagnostics, because technology has a massive role in the recent past, and it has helped us in diagnosis, treatment planning, and then further execution of the treatment. So talking in terms of newer diagnostics, you need to go step by step. I think a PET scan along with CT, so it is up to you. How do you see the question as newer diagnostic techniques in oral surgery?
Honestly, evolution has been so great, right? Evolution has been so great. When we were undergraduates, there were no OPG machines, right? When I was a undergraduate student, there were only IOPA machines, and we had to do with extraoral radiographs. We used to take like a lateral oblique view and a PA mandible. Plain radiographs have not become obsolete yet, right? In fact, actually, if you go to the clinics of North America about your investigations and other radiological ones, in fact, in certain parts of the world, they don't believe in OPG. They still take IOPA, the intraoral periapical radiograph, because of its precision, and the bite wing radiograph for almost all the dental related procedure, the proximal caries, etc., etc. So let us not write off any of the radiological investigative methodology. Saying that, the evolution from then has been quite rapid, right? It started off with, like what you say, we had our OPG, as I said, it came in the mid 80s. Then we had our CT scanners. The first generation CT scanners, like which we had like in one of our hospitals when I was first training, honestly, it will take 45 minutes to do one CT scan. The patient, a trauma patient or a tumor patient, will go into the CT room and will take 45 minutes of the CT time to do one patient. Nowadays, the CT time is less than a minute. The positioning, all those things might take a few minutes, right? But the CT time, the radiation time, is less than a minute, right? So the evolution, the first generation, second generation, third generation, we had our HD CT, right? The HRCT and all those stuff, right? The multi-detector CTs, they have revolutionized. And with the 128-bit, the 256 one, right? So almost the CTs have literally ruled. Now CT has become the gold standard. I don't see, we see any of our trauma patients without a CT scan. Nowadays, CT has become the gold standard. Do we stop here? I don't think so. The technology is so fast developing. Now we are talking about your, you can have prototypes, the models which you can have it in your hand. The treatment planning becomes so good, right? But then the other things which came in, every technology is basically a double-edged weapon, right? Radiation is a real and true danger. Now, when we start substituting our clinical examination for investigation, that is the problem. In fact, in many parts of the world, if you write for a CT scan, you are responsible for the amount of radiation what your patient is going to go through. In other words, you need to prescribe an ionizing radiation only if you feel that it is certainly necessary. There's no contraindication. You can take a CT scan for a pregnant lady if you feel the clinical benefits far outweigh the risk. There is no absolute contraindication. But at the end of the day, you are going to put the patient through multiple radiations. We also have to look at other modalities. Now, MRI is a great tool, right? Simple. It has no radiation. There's no ionizing radiation, but it has its own problem. It is an extremely claustrophobic area. It's like a tube. It's extremely noisy, even with the new generation MRIs, right? It is extremely noisy. We talk about MRIs, which can be used for a lot of purpose. It may not have a great bone resolution, but when it comes to soft tissue, its use in like pathology, invaluable in pathology. When we talk about trauma, the image what Dr. James has just now projected, we talk about the muscles, the extracorneal muscles. We are talking about the vitreous humor itself. Like you have in MRI, it has got different type of images, right? So your radiologist will be able to tell you that can differentiate the amount of, like what you say, the magnetic resonance which they are generating, whether that's a T1 image, T2 image. There are 4 different type of images which they can generate by the varying the resonance part of it. And they can differentiate very many different. They can say what is an inflammatory fluid, what is a neoplastic tissue, And when you add a contrast onto an MRI, that literally increases the sensitivity of the MRI. And TMJ, I guess Dr. James has got a video at some point. We will try to play the video at the end if time permits, right? Dynamic MRI of the temporomandibular joint. It's a gold standard whenever you talk about any patient who has got a temporomandibular dysfunction syndrome, right? Your MPDS, your temporomandibular dysfunction, your internal derangement. Dynamic MRI is the gold standard because you're going to see, that is the only thing. In a CT scan, you are not going to visualize your articular disc and the muscles which are actually supposed to be working together. We will try to show the video at some point, right?
Yes.
Dynamic MRI is the gold standard when we come to TMJ. Dr. James, the first picture he put is a PET scan.
Yes.
I'm sure you know about the PET scan, which is a positron emission tomography. Now, PET used to be, if you see the pictures on the left and the right, you can see areas of uptake, right? They give an uptake. It is, you wait for an hour and then you are going to put them through. It is going to show hotspots. It may not be a great use when we talk about the primary tumor. PET scan is largely used for malignancy, but it is also used for chronic infection. It can be used for another beautiful thing, what we talk about the RONJ, like we talk about the MRONJ, right? Medication-related osteonecrosis of the jaws, right? A PET scan can be a great one because it can have uptake. But PET scans have a problem. What is the problem? When you look at it, you look at a hotspot. You don't know exactly where the tumor is. So now what they are doing in the latest one, they are merging in a single machine. You have a CT as well as a PET. So it actually becomes an anatomy based. So the images in the center, it shows a CT of the mandible, which is married to a PET. And from the CT, they can also pick up a hotspot. So if the patient has got a chondrosarcoma of the say left condyle or the right condyle, it can pick up a hotspot. So it has the advantages of the CT, and also it can give, see, CT is anatomical based, MRI is anatomical based, PET scan is functional based, right? You talk about what is its activity. You are going to talk about hotspot and all those things in a PET scan. So that is the advantage. Now, PET is being married to CT, a PET CT, a PET MRI, a PET ultrasound even. Right?
Yes.
So I think there are a lot of advances as we are going. Now, I'm sure like there are many people who say that you need to adapt to change. Now, in every institution, that is one big advantage of having what we call as a heterogeneous group. What do I mean by the heterogeneous group? Experience has got a value, but that does not mean everything. You need to have young, dynamic people also in your team who can actually adapt to change very quickly. You should be able to learn, because technology is running at a rapid pace, and how we marry technology without falling for it, right? So I don't send every patient to PET scan. PET scan has got an indication. It's still pretty expensive. Dr. James was talking about the cost to a patient. It's still pretty expensive, and it's not so widely variable. And for a primary tumor, when you know that there is no evidence of any metastasis, PET scan does not have a great value. PET scan is a great one when you're talking about a follow-up patient or it's a recurrent tumor. If you suspect metastasis, that's a great one. Or you don't know whether this is malignancy or not, that's probably a great one, right? So I think you should not over-depend on technology, but adapt to technology and keep abreast with the changes which is happening.
Yes, sir. So to quickly sum up on that, how we have changed from the X-rays to the CT scans, to the PET CT, and then PET MRI, a dynamic MRI, and then a quick word about the cinematic rendering. Nowadays, we have the 3D volumetric reconstruction of the CT image. And then from there on, we have gone towards cinematic rendering, which is much more hyper-realistic about how the fracture has exactly is. If you can see these images, how it is slightly different from the volumetric rendered 3D image to a cinematic rendered 3D image. We have progressed there. And then it's a quick word about the TMJ arthroscopy, sir.
Yeah, see, TMJ arthroscopy now, arthroscopy has been done for a long time. Now, it was in the sort of the late 80s and the early 90s itself, and arthroscopy went in with a huge amount of one, but unfortunately, it did not keep pace for the simple reason, technically, TMJ arthroscopy still is not like what you say, it's like the first 100 arthroscopies what you have, it has to be the learning curve for any clinician with the TMJ arthroscopy is extremely high. It's not like the other big joints like your shoulder joint, your hip joint, where the cavity, joint cavity is fairly larger. So we are talking about a miniature. The TMJ, the condylar fossa itself is a miniature one, and into which you can use it as a diagnostic one. But arthroscopy will become complete only when it becomes therapeutic also. We are not talking about just a lavage. For doing a lavage, you don't need an arthroscopy, right? You can just put two needles, and needle arthrocentesis can be performed, which gives you pretty much the same result. However, if you are able to visualize that joint, and at the same time can use miniature rotary instruments, even grasping instruments, and then you can do like arthroscopy based discopexy, meniscal repair, these type of stuff. If you are able to do it via an arthroscopy, yes, it has a very long, like what I say, it is a steep learning curve. However, many centers in India are now going into TMJ arthroscopy with a renewed interest, with renewed, like what you say, knowledge with the imaging. Earlier, when it all came, dynamic MRI was not very common, but nowadays we get fantastic dynamic MRI. So which means preoperatively, we have a fair idea about what to do. And here, if you marry it with your skills with TMJ arthroscopy, I think we have a winner. I think this is future for us. TMJ arthroscopy is again going to have a renewed interest. The next decade, it is going to be a lot of endoscopic work which is going to be done in that area, I hope.
Yes, sir. So quickly talking about the advancements in the clinical applications of the latest technologies, we speak about the navigation surgery, and then how we can have a diagnostic planning based on the software which is available.
Yeah.
Whether we further evaluate on the CT, it is the CT what we have, and then we can further evaluate the CD stepwise. We can just mark up only the lesion, or we can predict certain orthognathic movements within the jaw bones, or we can also have a cutting guide. So all these developments have come forward because of the help of scientific advancements. And then quick word about the augmented reality, sir. It is coming into place. I think people in West have already started. All the diagnostic investigations, what we have, the CT scan, the PET scan, the MRI scan, whatever it is, we need to see it in the screen or in the film, and then we take it inside our brain and think we will formulate a 3D image within the brain and then look into the patient when we're operating. And with an augmented reality, if we can have a VR glass or an augmented reality glass, we can see what we have seen in the monitor over the patient, superimposed over the patient. That is what augmented reality is about, where we can superimpose the CT scan or superimpose the treatment plan over the patient, and then move the jaw bones and then make the necessary osteotomy cuts based on that. How helpful it is, sir?
Honestly speaking, Dr. James, I mean, I had the opportunity to go to one of this large hospitals, the Harvard University, Brigham and Women's Health Center, where that they have one of the largest simulation centers. And I was flabbergasted when the person in charge told me that no surgeon, they have a wonderful, like what do you say, a simulation center, what they call as a Da Vinci, which is now actually coming through in so many places. I believe every surgeon needs to go through a Da Vinci every 6 months. Literally, they do the virtual surgery, right? What you're talking about it, they can put the patient, they can literally do the virtual surgery. They can practice what they are going to do. This is just for the training part of it. See, when we talk about technology, flight simulation, right? Now, most of the checklist what every hospital has developed is based on flight, the checklist of flights, the flight plans. They have the multiple points checklist, right? Our theater checklists are like that. So Da Vinci is one of the things like what we talk about, like what I say, every surgeon need to be trained, like what I say, in simulation. Now that when they transferred it onto the patient, it became navigational. So we have a particular setup where we know exactly what we are and we can look at it on the screen. When we touch it, the knife shows exactly on the CT where we are. So do we have to go up, down? Everything is shown in the augmented reality, even the navigational surgery. Navigational surgery is a reality right now in Chennai. In fact, actually, I'm sure you guys would have listened to Dr. Anand, who's actually doing a lot of this navigational surgery for the orbital repair, right? He's doing it in one of the big centers, which has got that setup, right? Most of it is extremely cost intensive, right? But there is a setup very much in our own Chennai, right? And I'm sure this is something which will start coming through. So yes, technology wants you to it. Like if you can bring to the betterment of the patient care, because the precision increases. Earlier, there were like most of this 3D planning and the stuff, it has increased the precision, what the procedures, what we were doing normally, right? So
Yes,
that planning is fantastic with the newest technologies.
Yes,
And of course, he showed what do you say, the robotic surgery, where at the end of the day, still it needs to be, what do you say, guided by a human, but a human has got, like if I'm holding a knife and if my hand is shaking, right, that is not going to happen with the robot, right? If we're talking about precision, it can go and touch it, but you have to program the robot to do exactly what it is.
Yes, sir. Yes, sir. So next question to quickly discuss is about the contrast CT, MRI. I think we already discussed about that. We'll quickly go through this question, running short of time, sir. And then the last question about the lesions. Specific points of differentiation between a plain CT, a contrast CT, and an MRI. We have gone through this step by step, how in 1895 it had started and how it is, how we're using a CT in all 3 dimensions. We start to analyze the patient based on the anatomical region of interest. Okay, and how the CT scan has helped us to diagnose with saying that, sir, in the things of the past, as you said, sir, based on experience. Certain individuals are like, why are you unnecessarily taking all these investigations? At times, even the patient will ask us, why are you asking us to take all these expensive investigations? Is it still the same, sir, or investigation has moved us forward in treating, in giving better treatment for the patient? How do you feel that, sir?
I think there is no question about it. It's just that like we need to use technology. As I said, it is a double-edged weapon, but we need to be very clear. Now, how you could reduce it is, say, for example, if you suspect, most of the time we don't even suspect, we know it when we see a cancer patient, that it is a, like what is a malignant lesion. You have done a biopsy, you want to do a CT, you would want to do a CT beforehand, do a biopsy, and then have a report. And then before doing it, you want to do a CECT. That is like what I say, you are misusing investigations there. But more importantly, the amount of radiation what you're giving to that patient can be harmful. So if you know that this is what you're going to do, a contrast enhanced CT is probably the gold standard if you want to operate on any malignancy as it stands right now, right? Because you need to know the extent of the lesion. You need to know, see, we talk about the clinical staging, we certainly need to know about the radiological staging also. How much the uptake is there in that particular tumor? Are there any of the nodes? See, nodes positive, clinically positive nodes is like we talk about a lot of characters. Now, when we have a CECT and a contrast enhanced CT, the nodes are also going to uptake the contrast, which will mean that those nodes are malignant nodes and your treatment plan grossly changes. The N0 neck can become an N1 or an N2A, or for that matter, it cannot become an N3, because that you will never miss. I mean, you're talking about this bigger node, you're not going to miss it, right? But if you have multiple nodes, right, you should be able to pick up with the contrast enhanced CT. And that gives you a fantastic idea about how you are going to plan your resection. You are not going to go only for your field technique. Yes, field technique is good, but a contrast CT is a must. Now, plain radiographs in most of these things are going slowly obsolete, right? So say, for example, nowadays, any trauma patient, nobody bats an eyelid. We need a CT as a gold standard, right? We hardly do a treatment with one PA mandible, right? A CT scan is always a must. So CACT is fantastic in malignancy. It's not just in malignancy. Now, there are certain infections when you want to look at it in another thing. Also, I think Dr. James has got a very interesting case. Would you like to tell about that, Dr. James?
Yes, sir. When do we do an under investigation? Certain times, for example, this 58-year-old patient was having some toothache in relation to the right side maxilla for the past 1 year, and she is moving here and there. Got her one of the molars extracted, got one of the premolars extracted, but no relief of pain. All of a sudden, what she developed is she developed a huge swelling in the face, and then with certain antibiotics treated elsewhere, it has come down. And ultimately, if you can see this image on the left, she had developed pus discharge from the medial aspect of the left eye. But still, the patient's complaint is she has some dental pain. When we took an OPG, obviously she had an impacted canine tooth in that particular region. And when we palpated clinically, she has pain. So immediately, we also were into a conclusion in this case that it might be because of the impacted tooth, which is resulting in a space infection. And then it is tracked down somewhere where the bone is very thin and the infection has been, it is coming out. But it was not so, sir. So when we took a CT scan and a contrast enhanced CT scan, it clearly showed that it was a cystic lesion within the ethmoid sinus. So talking about extractions, because the patient has gone to various dental clinics, they have extracted the molar, they have extracted the premolar, prescribed antibiotics, analgesics. That has been continuing for more than 1 year. If we had run through the investigations properly before, got a good clinical examination of this patient, then we would have picked her up much more earlier. So to sum up, sir, as you had told, we start with the basic of the X-rays. Certain times it becomes absolute. We do not need an X-ray at certain times. We can directly go into a CT scan. And as you told, sir, whenever it is the soft tissue which we need to evaluate, as in case of a cancerous lesion, if we're evaluating the extent of the lesion into the muscles, the extent of the spread of the disease into the lymph nodes, we need a contrast enhanced CT. And then certain unknown disease, maybe when we are treating, when we take a PET scan. So a quick word on when do you prescribe a PET scan for the patient?
But I think it is a very controversial thing in that, like a PET has been like now slowly being sold as a gold standard for all malignancy. But if you speak to most of the oncosurgeons or people who are practicing oncology, when we are talking about a primary tumor, PET is not a must. Only thing is, if you look at it and then you already see more than one tumor. See, if the patient can have two simultaneous tumors, the upper aerodigestive tract, you feel this patient has got multiple one. Or if you have a lymph node with an unknown primary, you don't even know about it. The definitive indication is you suspect recurrence. You are talking about a patient who has got a suspected metastasis. Those type of ones, a PET is a must, no question about it. An unknown primary, a suspected recurrence, or a suspected metastasis. These three conditions, I will certainly advise a PET. PET, now with the new generation PET, which is married with the CT, the thing is it can be a much more specific in that the CT can give you tissue changes. Your good radiologist can pick up a lot of the fat plain tissues and other stuff, and then they can give you an indication of the extent of the tumor. Now, if you can get a PET CT or a PET MRI, that is going to be the next generation. You are going to get the anatomical delineation of the tumor as well as the, like what you say, the functional activity of the tumor. So the new generation PET MRI, the PET CT is probably going to change the game. But as it stands right now, we are talking about a pure PET, which only gives you hotspots. They are great for specific regions. But when the new generation comes, I guess that will become the gold standard.
Yes, sir. Okay, so we'll just running slightly short of time. So we go on to the next question. So what is the current for performing minor procedures in patients on anticoagulants and antiplatelets? Can we take the call, or is it mandatory to take a consent?
I think that question will be the most controversial question, and it will remain to be, right? Everybody can give a protocol, but believe me, if you have, like, the principle which I follow is, I have prescribed a drug, I have the right to stop a drug. If I did not prescribe the drug, I do not have the right to stop the drug. That is the philosophy I follow. And you speak to any of the so-called, like what you say, hematologist or cardiologist and other stuff, a bleeding, speak to a hematologist, a bleeding problem, it can look alarming, but it's rarely, I'm not saying it is never, rarely life-threatening. However, a thrombotic event, it can be life-threatening, limb-threatening. The consequences can be pretty bad. So I will think 100 times before I stop antiplatelet therapy. However, there are some very nice protocols. You can communicate with the physician. I still say you better communicate with the physician. If you're talking about a low risk, you don't need to do anything. And if they are in the right thing, if they are on a single antiplatelet therapy, more often than not, you can manage with the local hemostatic measures, right? You can do a proper hemostasis, you can use lasers, you can reduce the amount of bleeding, you can use hemostatic agents, you can use suturing. There are a lot of ways of actually controlling the bleeding, local effects, right? And you can use even tranexamic acid as a topical, as a mouthwash. There are many things which you could do. If you have to stop, then I would seriously suggest better get the opinion of the physician who's in charge of it. There are some people who are in a high therapeutic value, right? We talked about both antiplatelet as well as anticoagulant, right? So there are people who are on artificial valves, particularly like a prosthetic valves type of one, right? Like, or you can also have bovine origin type of one. But if you have those type of valves, those are not patients who can afford to have a thrombotic event, right? That can be a real disaster. Those patients might even need to go into what we call as a bridge therapy. So if you have to stop, make sure that you discuss it with your cardiologist the person who is in charge of it, of the antiplatelet or the anticoagulant, what the patient is taking. If you can manage, if you think that it is a low risk, a medium risk, if you can manage with local measures, please go ahead and do that. But if you stop, I think I'll better stick to my stand that better get your opinion before you stop.
So we also need to understand about how they manage, whether it is a single drug therapy, single antiplatelet drug therapy, or a dual antiplatelet drug therapy. Usually they say that whenever the patient is in clopidogrel, we can see the classification of the drugs based on the antiplatelet and the non-vitamin K based oral anticoagulants, which have been coming into the market recently, sir. The non-vitamin K oral anticoagulants, which has a much more specific time period of action. For example, the dabigatran, edoxaban, all of this have a very specific time period. Within 24 to 36 hours, if you stop that for a minimal of a 1 day, you can directly extract. But as you said, sir, consent from the cardiologist or consent from the concerned physician is of prime importance. We can definitely extract. For example, there are many articles which support about doing a minimal surgical procedure for a patient who is taking aspirin alone, 75 milligrams, no need to stop. You can directly go ahead and extract. And these also depend upon the underlying cardiac disease of the patient. If the patient is taking prophylactic aspirin, nowadays, patient above 45, 50 years, they take prophylactic aspirin. So in those patients, can we advise them to stop? or what do you prescribe, sir?
Yeah, as I said, like it is the horses for courses. If you are talking about a prophylactic one, more often than not, if you have an elective surgery, see, extraction is a different kettle of stove. But what happens if the patient has got a zygomatic complex fracture? The patient needs an intubation, right? Those type of patients, so you are obviously going to stop the antiplatelet therapy, but the patient is going to be hospitalized, right? And based upon the risk, the cardiologist is going to say, well, he's only on a prophylactic one, no problem at all. We will keep him under observation, and then you go ahead and stop it for 5 days and then go ahead and do the intubation, do the surgery, finish it, and 2 days later you can start it. However, if a patient is on therapeutic level, the same patient gets admitted, the same patient, all the antiplatelets are start, but the patient is started on some form of a heparinoids, right? The low molecular weight heparin and other stuff, to make sure that the patient is not going into a thrombotic event. Maintain that and then do the procedure. On the day of the surgery, you reduce it, you stop that your heparin or your low molecular weight heparin, finish the procedure, get the hemostasis, and the next day you start it. So it's a balance. So if you feel that a patient is on a therapeutic one, ideally the thing needs to be balanced. If they are on prophylactic, more often than not, you can happily stop.
Yes, sir. It's also important to know about these drugs, sir, because sometimes the patient comes with a prescription with a commercial name or the brand name, and we could look over. We do not catch off these drugs. It has to be.
Yeah.
It has to be. And then the bridging therapy, sir, for warfarin or coumarin-like derivatives. Definitely, we switch over to the low molecular weight heparin. We stop warfarin for a period of 5 days. So we stick on to that. Definitely, these are patients definitely to be referred to a cardiologist, and even the surgical procedures, if preferably, to be done under hospital setting.
Absolutely. These people are all admitted. They are kept under strict observation. And INR is like what you say, you're talking about the PT is regularly monitored. Bridging therapy is under observation. You can never discharge that patient. Those patients need to be
Yes, sir. So the last question. Investigations for
somebody is just putting a question on indications of blood culture. See, blood cultures, you do it when your patient is septic, whether you're talking about a patient who has been admitted with infection, but more often than not, if you have a major surgery patient, if you have a patient whom you have been operated for major oncological resection, these patients are likely to be there in the hospital for some time. They will catch infections. There are multiple portals of entry. Blood culture, I would always say, when a patient is running 101 degree and above, when the patient is pyresic, take a blood culture. So take a blood sample. You ideally need to take 20 ml of blood, 10 ml for an aerobic culture, 10 ml for an anaerobic culture. It comes in 2 bottles, and that needs to be given to the microbiology this thing immediately. That's a good question. And that, believe me, blood culture will become positive only when you take blood when the patient is pyrexic. Not when the patient was pyrexic in the morning and you take a sample now, you are likely to get no growth. Right? You are talking about in a septicemic area, like when the patient has got the bacteremia, you take a sample, you are likely to grow the organism which is causing one.
Yes.
That's
yes. The last question, sir. Investigations for vascular lesions.
Vascular lesions.
So if you can quickly describe about an hemangioma and a vascular malformation. So that's one of the commonest doubt as a PG student, what we have. You can quickly tell us that.
Yeah, see, a hemangioma and a AV malformation, right? An arteriovenous malformation. Now, hemangioma is something which more often than not, you see something which is at birth. It's like a birthmark, right? You can see a lot of these type of port vein stains, like you talk about strawberry lesions, there are cherry lesions, etc., etc. They keep talking about it, right? So it's usually diagnosed early, and it can even regress on its own. Very rarely it has got a deep involvement. I'm not saying it does not happen. Stooge-Weber syndrome, which actually is a port vein stain type of one, it can have a deeper involvement also. Usually they are extremely, like what you say, they are benign. Apart from the fact that they look very odd, these people can grow with that. But if you have to do any procedure, even in a Stooge-Weber syndrome, when the patient has got a sort of a one form of maxillary division, you will see that it's entirely discolored. If you end up doing an extraction in that area, you're a nightmare, right? You might have to speak to your hematologist. You might have to, sclerose that area before you go ahead and do the extraction, because that can have a problem. Vascular malformations or the AV malformation is a very different kettle of fish, right? We have got a lot of classifications, right? There are some lovely books. And one of our immediate past president in AOMSI, Dr. Sanjeev Nair, has got very special interest on vascular malformations. In fact, he came in with his own classification also. But what is the most acceptable classification is what this comes from, what we call as the International Society for Study of Vascular Anomalies, right? And they have come in with 3 different modifications. The latest one is 2014 in the Melbourne thing. They have come up with the classification, and that's the current classification of all AV malformations. So hemangiomas can just be observed, or it can treat it cosmetically, or you can treat it symptomatically. However, AV malformations are a different kettle of fish. More often than not, you might have to do an intervention. Now, more importantly, you need to know, one of the biggest thing is Dr. James has got a fantastic case. Like, I think I would try to show that thing also. Can we go to the next one, please? Yeah, this is a patient, right? Now, this patient, if you actually look at it, this is a very young boy, has come in with a mobile tooth. And I believe, but Dr. James, you want to just tell about this?
Yes, so a 6-year-old who slowly developed as swelling. The main complaint was the patient was not able to have his food normally. And then the patient had no idea. And they said, one of the teeth has been infected, kindly do the extraction. So that is the scenario what the patient comes in. A huge swelling mimicking something like a dentoalveolar abscess. The tooth is mobile. And then if we had not intervened at the right time, possibly I think they would have extracted this teeth, doing an incision and drainage of the abscess. So that's where clinical examination becomes of much more importance. Just running through your index finger into the swelling, you can feel the pulsations in your finger. Nothing much to do. Just put in your finger, you see the pulsations in arteriovenous malformations. That is what we had for the patient. We got the CT angio done, and that is what the extent of the lesion for the small boy.
In fact, actually, this is what they call as the DSA, or the digital subtraction angiography, right?
Yes,
now, can I quickly change it into my screen share if that is
yes,
okay?
Sir, please.
Sorry, we'll just quickly go through that one. I think we are going to show the same thing, right? Sorry about that. I should have just got it ready. Yeah, okay. Okay, this is what Dr. James was saying. A quick go through that. We will come to that later, right? This is the same patient, which, are you able to screen my screen?
Yes, sir. Yes, sir.
Yeah. So that's a digital subtraction angiography. Now, there is another young boy. This is a 12-year-old boy, right? Which we happened to operate just a few months ago. You can see that this boy has got a huge lump, and this lump apparently becomes huge when he starts throwing a tantrum. That's exactly what his mom told. He's a 12-year-old boy. I mean, you can see it. And this increases so much, and it really bulges like that, right? Now, this boy has got a huge lesion in that area, right? Now, again, this is an AV malformation. It's a high flow lesion itself. Now, this wouldn't have been possible if not for just the investigation. You can take it one step further, and then you talk about the interventional investigation, right? We talk about embolization. Embolization. Now, this is a patient intraoperatively. I'm just going to quickly show, right? That's the lesion. we made the incision right across because still for AV malformations, even if we embolize, these people can bleed in no time. It can bleed a huge amount. And for young persons, even if you start bleeding about 500, 600 ml of blood, right, that is huge. So one of the first things what we do, we open up the neck. Even before we go into the lesion, you have retracted your IJV, you have seen your carotids. That is the common carotid. That's a bifurcation. Usually it is the medial branch is your external carotid, but you never ligate the medial one. You have to make sure that you see at least one branch. You keep that under your control, and that is what we did, right? Then after having a ECA under control, we did not ligate it. This is a patient who had the embolization done. I will just talk to you about that embolization. That is that particular tumor. Now, if you look at this particular thing, this is before embolization. This is the patient's cannula which is going in, right? And then it shows that the entire lesion got filled, right? If I have to just show it back again, right? So you can see it. This is the entire lesion getting filled, right? It has got so much of blood flow into that area, right? So in the next slide, right, they had embolized it because they have cannulated that area. They have embolized it. And then when they are putting in the contrast, you can see it. Now there is ectasis of the vessel, which is the supply feeder, but inside the lesion, it has got multiple clotting. You can give intralesional bleomycin, which will make the tumor nice and firm. You can actually give nanoparticles. You can actually give microcoils inside it, which will go and stay in that lesion. In fact, in our clinical picture, if you actually look at it, that really looked, we were able to, it's a huge tumor. It's a huge tumor. We were able to get it out in one piece and with literally minimal to next bleeding. Okay. So yes, I think investigations, you can take it to the next level. You have to use your investigations appropriately to get the best for the patient benefit. Yes, right. And can I just show the couple of MRIs which Dr. James has put in? I think it is the last bit. We are just finishing in the next minute or so. Now, these are certain dynamic MRIs which Dr. James has put in, right? You can see the activity of the muscle when we talk about the dynamic MRI. Now, I'm not sure about this particular MRI's diagnostic value here, but you can see the muscles. But this one, when we talk about an MRI of the TMJ, right, we talk about the temporomandibular joint dysfunction and the internal derangement type of one. So you can see the condylar head, you can see the articular disc, and I'm sorry, it is slightly rotated. You have to see it. That's a condylar head. It's getting pulled, and you can see the lateral pterygoid muscles, which actually literally brings the thing. I'm going to play it once more, just in case. Like, okay. So when you do it, you can literally visualize the articular disc. You can see the upper joint cavity. You can see the lower joint cavity, and all those things are so cleanly visualized. So in a nutshell, Dr. James.
Yes, sir. So a thorough clinical examination does not, it outweighs all the other investigations, because based on a clinical examination, you choose the investigation tool. Plan your investigations based on the priority. Know when the advanced diagnostic test is required. You validate your clinical diagnosis always. Whatever is a clinical examination, clinical provisional diagnosis you give, you always validate your clinical diagnosis with good, sound diagnostic investigations, and you plan your surgery based on your scientific evidence. So we'll finish off with the first session. Thank you, sir. Thank you for sharing your knowledge with us.
Thanks a lot. Thanks a lot. And that is our team. And thank you very much, Dr. James. And that's all. Thanks for the organizers for giving us an opportunity.
Thank you, sir. Thank you.
Can you hear me, Dr. James?
Yes, sir. Yes, sir.
Can you just
so we'll start with the, yes, sir. We'll just start with the session.
Is my screen sharing seen?
Yes, sir. Yes.
Yeah.
Let's see.
Just a minute, please.
Yes, the next topic for discussion will be nerve injuries and neuralgia. Pretty much from the basis of an impaction, minor oral surgical procedure. We need to be careful about dealing with nerve injuries and how to avoid nerve injuries as such. Because to start with, as an oral surgeon, we'll be predominantly doing most of the minor surgical cases, which starts with impaction. Even though it is a very simple procedure, chairside procedure, it has its own technical details regarding the nerve injury. Because if ultimately if you end up with a nerve injury, it is going to be tough on the patient. So a very important topic to be discussed, very least understood by most of the postgraduates. Even when I was a postgraduate, it was least understood. I think Krishnan sir will clarify all the doubts about the nerve injuries, how to avoid it, and how do we treat it.
Good evening to all of you. I was worried some time ago that I would have to say good morning instead of good evening, but better late than never. So I have been given this topic on nerve injuries and neuralgia, and I was given some questions posed by some of the postgraduate students earlier, and I was asked to prepare some answers for them. So let's get on to the questions. First question that was asked was about the inferior nerve and the lingual nerve, its variations and its common anatomical locations. Just a minute, please. Yeah, so we all know that the inferior nerve is a branch from the sensory root of the mandibular trigeminal nerve. This nerve enters the mandible through the mandibular foramen, traverses through the mandibular canal, has a loop near the mental foramen, and exits out through the mental foramen with a part of the inferior nerve proceeding further as the incisive nerve. But is that all that is to the anatomy of the inferior nerve? Several variations have been described. To start off, the inferior nerve, after splitting from the infratemporal fossa, can split over here and rejoin back as a single nerve before it enters the mandibular canal. There have also been instances where they have documented connections between the lingual nerve and the inferior nerve. Within the mandible itself, the inferior nerve can run through the mandible either as 2 or 3 distinct nerves, either in single or separate mandibular canals. And a rare occurrence would be the presence of bifid canals. These bifid canals could be present unilateral or bilateral and may extend into the various zones of the mandible. Rarely it is also seen that the bifid canals may fuse after a certain distance in the mandible and then proceed as a single mandibular canal. Now, Correr et al. And Naito et al. In 2013 and 2009 have given some classifications on the relationship of the bifid canal to the third molar and to its relationship to the buccal and lingual cortical plates. If any postgraduate students are interested, they can refer these articles for some more information on bifid mandibular canals. Now, I did mention that the inferior nerve has a loop near the mental foramen. The nerve proceeds in an outward, backward, and upward direction before it extends out from mental foramen. Now, this anterior loop, is it present in all patients? The surprising thing that is that there seems to be a high diversity in the presence or absence of the anterior loop, with anterior loop being present, range being from 0 to 80%. And the mean length of the loop has been found to be about 0.1 to 11 millimeter in length. So this mean length brings into question whether the guidelines that have been given by implantologists that it is always better to place the implant 2 millimeter anterior to the mental foramen so as to avoid damaging the loop is called into question. And probably this means that every patient should be individually assessed rather than depending upon general guidelines. Studies have also shown that there are different, in the absence of the anterior loop, the mental nerve may extend out from the inferior nerve either posterior to the exit from the mental foramen, or it may exit out at right angles to the mental foramen. Whereas when there is a presence of the anterior loop, the mental nerve branches out in an anterior direction. These are some of the variations that are observed in literature with relation to the inferior nerve and the mental nerve. But does it end there itself? Now, we are also interested in knowing what is the relationship of the inferior nerve to the buccal cortical plate of the mandible, to the lingual cortical plate of the mandible, and the inferior part of the mandible, all of which have clinical significance in procedures such as implantology, placement of mini plates and reconstruction plates, and orthognathic surgical procedures in the mandible. Now, studies have shown that in general, the inferior nerve is at a distance of about 10 millimeter from the inferior border and about 5 millimeter from the buccal cortex. As regards to the buccal lingual position of the mandibular canal, this depends upon whether a narrow space is present between the canal and the buccal cortical plate. In those instances where the narrow space is present, the mandibular canal tends to be more in a link closer to the lingual plate than to the buccal plate. Of particular importance to us is that the inferior canal is most closest to the buccal cortical plate at the third molar region and is much away from at the first molar region. This is a reason which was taken advantage of in the modifications of the sagittal slit osteotomy, so that the anterior cuts are now made at the region of the first or second molar and not at the third molar as previously described, to minimize the risk of injury to the inferior alveolar nerve. Coming on to the other nerve that we are very familiar with, the lingual nerve. Again, another sensory branch of the mandibular division. It runs between the levator palati and the lateral pterygoid muscle, and then between the lateral and medial pterygoid muscles, where it lays anterior and medial to the inferior alveolar nerve. And reaching the pterygomandibular space, it is usually between the lateral surface of the medial pterygoid muscle and the medial surface of the ramus of the mandible, before it moves on to the mucosa of the oral cavity close to the third molar, and then gives away terminal branches to the tongue and the floor of the mouth while looping through the loop of the submandibular duct. Now, this is the anatomy that we have all learned from our first year. But is that all to it to the lingual nerve? Now, Kieselbeck and Chamberlain have found that the lingual nerve in their study was about 3.4 millimeter medial to and 8.3 millimeter below the alveolar crest. And they also observed that in about 15% of the cases, the lingual nerve is actually above the alveolar crest. In relation to the mandibular third molars, studies have shown that the lingual nerve is usually at a greater distance from the distal surface of the mandibular third molar rather than the mesial surface. Variabilities have been noticed with relation to the lingual nerve in relation to the lingual crest and lingual plate, with a considerable number of nerves remaining in contact with the lingual plate or at or above the crest. Such variable pattern of the nerve makes it highly vulnerable to injury during dental-alveolar and oral surgical procedures. What about any variations in its route along the floor of the mouth? Now, Al-Samiri et al. Have found that in general, on an average, the lingual nerve traverses about 25 millimeter and starts deviating between the mesial of the first molar and the distal of the second molar. In most individuals, they found that the average diameter of the loop of the lingual nerve around the submandibular duct was about 6.92 millimeter. And in a majority of patients, this loop started at the third molar region rather than at the first molar and second molar region.
Yes.
So that would cover some of the anatomical alterations of the lingual nerve and inferior nerve that would be of interest to the postgraduate student for their examinations and also for clinicians who perform surgical procedures in this area.
Yes, sir.
Yes,
So quickly, certain clinical oriented questions. Talking about how close the inferior nerve is there in relation to the third molar. I have certain questions, like when there is an angle fracture, when you are putting the screws in the angle region, how much should be worried about whether we are injuring the nerve if it is placed on the buccal side? or we're injuring the tooth, in that context, in the angle region. And then when there is a fracture in the parasymphysis region, when we're opening up the flap, we see the mental nerve. How do you take precautions to preserve the mental nerve in that region? And then during impactions, how do you preserve the lingual nerve? And then any incisions in the floor of the mouth, whether they might be a small mucocele or maybe a small salivary stone. When you're removing that, what are the precautions you take for preserving the nerve as such?
So with regards to your first question of the positioning of the screws in mandibular angle fractures, now we all know from Champy's lines of osteosynthesis that although the ideal position for putting the plate would be the neutral zone is not safe precisely because of the fact that the infraocular nerve is there. And I have shown it to you in studies that the infraocular nerve is about 5 to 6 millimeter away from the buccal cortical plate, which means that it is at a higher risk for getting injured when you end up putting a screw. So as long as you ensure that your plate is positioned above the neutral zone, which is what Champy has recommended, that is the upper border oblique ridge plating, you would be having much less minimal risk of injuring the infraocular nerve. Another precaution that one could take is if one is worried about the anterior limb of the plate, screws of that plate causing injury to the infraocular nerve, you put a shorter diameter screws, shorter length screws for the distal portion of the plate and longer length screws for the proximal portion of the plate so that there is adequate stability of the fracture. Now, as regards to the mental nerve, placement of the incision is the most critical factor. I generally tend to place the incision more towards the vestibular aspect and do sharp dissection, ensuring that I reach down to the mucoperiosteal flap and mucoperiosteum, and I place the incision over the mucoperiosteum under direct vision, taking care to ensure that I am not injuring or violating the integrity of the mental nerve. A certain amount of sharp dissection along the branches of the mental nerve would significantly loosen the mental nerve and allow you to gently retract it away from the surgical site. And what were the other points, Dr. Bhagat? You asked me too many questions. I'm not that young to remember all the questions.
So especially the parasymphysis region, when we are putting in the retractors to expose the lower border of the mandible, we tend to have a strain on the nerve. Will it add on?
So the strain of the nerve can be avoided by careful dissection along the nerve so that all 3 or 4 branches of the nerve are well visible. And if you ensure that you have done a proper dissection of the nerve before you start retracting the tissue, you will find that the nerve is quite amenable to being pulled across along with the retractor and does not tense. If the nerve is tensing, it means that you have not dissected the nerve adequately and you have to go back to dissect the nerve more carefully before you come back, put on your retractors to expose the inferior border.
Yes. So the third question was about the lingual nerve preservation during impaction. Do you oftenly elevate the lingual flap, sir? Do you oftenly elevate the lingual flap?
I think I will be coming to that point in some of the questions that were asked later. So I would kindly be patient for a few minutes.
Yes, sir, sure. The final question was about surgical manipulation in the floor of the mouth in regards to the lingual.
As regards to the surgical manipulation of the floor of the mouth, you can see that from Al-Samari's studies that the lingual nerve is extremely quite unpredictable in its topography along the floor of the mouth. As a surgeon, I think the best thing that you can do is to ensure that the incision is kept as close as possible to the lingual surface of the mandible, keep yourself in close proximity to the lingual plate and dissect under good vision. And if you have loops, please use loops. Definitely you need a good assistant who is able to move away the quite annoying tongue from the surgical site. and often you would require the assistant to also provide some certain amount of tension in the submandibular region so that the submandibular tissues are tensed, which permits you to place your incision and do your dissection more easier rather than when it's a mobile tissue. So try to keep the incisions as close as possible to the lingual surface, and keep looking out for the submandibular duct, because the nerve has a tendency to loop around the duct before it goes towards the tongue, and that would serve as a landmark for you to know that you are close to the nerve.
Yes, especially in the floor, anteriorly we stay close to the lingual cortex, and as we go posterior, we slightly move towards the medial aspect. Is that right, sir? Because the lingual nerve courses from the lateral aspect and then moves medially, if I'm not wrong. Is that precautions?
Yeah, but what I have to say is that it is rare. It's only on rare occasions that your lingual incision has to extend up to the third molar. If you are going to do a sublingual gland excision, or you are going to look for removing of a sialolith, most of your time your incision would be limited up to the mesial aspect, or at best the distal aspect of the first molar. In such situations, keeping incisions close to the lingual surface of the mandible makes more sense. Like you said, that the more posterior you go back, remaining close to the lingual surface of the mandible does have a theoretical chance of damaging the nerve, because at the third molar, the lingual nerve is closest to the oral mucosa. I think care should be taken when you are placing an incision, and be careful with your dissection in the future.
Yes. Thanks, sir.
Yeah. So the next question I was asked was about the identification of facial nerve, its variations, tracings, and landmark points. So the facial nerve was probably first described in detail by Davis et al. In 1950, who described 6 branching patterns. They observed that the facial nerve, after its exit from the stylomastoid foramen, tended to separate into a superior temporal branch and an inferior cervical branch. And in their pattern of facial nerve branching, they found that the mandibular and the marginal mandibular and the cervical branches almost exclusively came out from the inferior division of the facial nerve, whereas the buccal branch had, to a large extent, some sort of connection to the inferior division of the facial nerve, but its relationship to the superior division of the facial nerve was quite unpredictable, because of which they were not able to predict what will be the amount of interactions between the buccal nerve and the superior division of the facial nerve. So basically they gave 6 divisions. Now this was further modified by Cans and Catalano in 1980. He came down to 9 subdivisions of the branching of the facial nerve, of which the third division. This classification was based on the terminal branching, the origin of the buccal nerve, and the presence of the number of facial nerve trunks. And in that study, they found that the type 3 variant was more common in their patient population in comparison to the other types. Now, it has been found that there is considerable differences in the facial nerve branching pattern in different populations. There have been studies from India, Pakistan, from the southeast regions, similar to Cans and Catalano, that have tried to examine the facial nerve branching, and they have found different facial nerve branchings in different racial populations. So, comparison of facial nerve branchings amongst population groups is a little bit difficult and complex because it tends to be varied. Now, as all surgeons, we are very interested in knowing how to identify the facial nerve and prevent any damage to it. Some of the identification landmarks, the most important would be what is known as the tragal pointer. Now, if one comes down along the inferior border of the tragus, they would find that it becomes, it ends in a sharp point, and this point is known as the tragal pointer. And the facial nerve is usually said to lie about 1 centimeter inferior and posterior to this tragal pointer. Now, why this tragal pointer is so popular amongst surgeons to identify the facial nerve is that there's an excellent avascular plane that just lies anterior to the tragus, and this allows the surgeon to quickly and easily dissect up to the tragal pointer without any bothersome bleeding. The other landmark that has been commonly described is the posterior belly of the digastric. Here, as one moves along the posterior belly of the digastric, they will find that the facial nerve is just present laterally at the upper end of the posterior border of the, at the upper end of the posterior end of the digastric muscle. The third landmark that is commonly mentioned is that when one draws an outline of the mastoid anteriorly, it is found to have an angle with the tympanic plate, and this angle is known as the tympanomastoid suture, and the facial nerve is said to be about 6 to 8 millimeters just distal to the tympanomastoid suture. Can the styloid process be used as an identification landmark for the facial nerve? It's a little bit controversial because you can see here in the picture that the facial nerve is lying posterior lateral to the styloid process. So if I am going to dissect looking for the styloid process as a landmark, I would have already encountered the facial nerve before I reach to the styloid process. So a lot of otolaryngologists and surgeons who deal with this kind of surgery recommend that the styloid process not be used as an identification landmark for the facial nerve. The other ways of finding the facial nerve would be to do a retrograde dissection using the buccal and marginal mandibular branches. The buccal nerve can be identified by its relationship to its parotid duct, and the marginal mandibular branch should be lying superficial to the retromandibular plane. And lastly, otological surgeries often use a nerve stimulator where electrodes are put along the orbicularis oculi and the orbicularis oris muscle, and these muscles will twitch when the surgeon's electrode comes close to the facial nerve. I think it is more relevant in middle ear surgeries rather than pure maxillofacial surgeries, where we are going to be operating in that area itself. Dr. James, would you like any clarifications on the facial nerve?
Yes, sir. Especially when we're surgically treating the condyle, what incision do you prefer, sir? And what precautions you take? What is the area where you would dissect and get into the ramus of the mandible?
Okay, so let me see whether the picture is there. Yeah. Is my pointer visible on the screen, please?
Yes, sir, it is visible.
Yeah. So you can see that there is a nice gap here between the buccal branch of the facial nerve and the marginal mandibular branch of the facial nerve. It is this gap that we surgeons try to take advantage of when we try to reach to the condyle or to the ramus of the mandible or to the angle of the mandible. Okay? So condylar surgeries, the surgical exposure would depend upon the level and extent to which you want to reach the condyle. Condylar fractures or subcondylar fractures can be easily accessed through a retromandibular, sometimes even a submandibular incisions. You put a retromandibular incisions, you can go through the transparotid approach where the chances of encountering the branches of the buccal nerve or branches of the marginal mandibular nerve are there. If you go through the anterior parotid approach, the chances of visualizing these nerves is almost minimal, and that seems to be a more safer approach. But if you want to use the get exposure to higher condylar fractures or to the zygomatic arch itself, then you would have to place a preauricular incision with a temporal extension. A critical area here to remember is that the facial nerve tends to be deeper just below the zygomatic arch, but as it reaches up to the lateral portion of the eyebrow, it tends to reach a more superficial zone, which is where the nerve can get injured. And that is why we place the incision just 2 centimeters above the zygomatic arch to take advantage of the fact that the nerve tends to divide into 2 branches, which may which then join up with the temporal fascia. The critical takeaway point from facial nerve branching is, to the best of my understanding, is that all studies have shown that there is a excellent communication between branches, with the exception of the temporal and the marginal mandibular branch. So this means that if you have injuries to the temporal portion of the facial nerve or the marginal mandibular branch of the facial nerve, these injuries are more likely to be permanent in comparison to the zygomatic and buccal, because there is good amount of cross communication and interaction between these branches.
Yes, sir. Thank you.
Yeah. So the next question I was asked was to give differential diagnosis for facial neuralgia or trigeminal neuralgia. Yeah. So the diagnosis of neuralgia is almost always dependent upon patient history. There are no diagnostic aids or radiological investigations that can help you tell that the patient is having neuralgia. So before one diagnoses a patient as a neuralgic patient, it's important to know which kind of patient is not likely to be a neuralgic patient, what we call as red flags. If on your examination history taken with the patient, you find that there are abnormal oral, dental, or ear findings, patient is less than 40 years of age, typically the pain lasts for more than 2 minutes, has a bilateral involvement, and most importantly, shows the absence of refractory period, you can be pretty sure that the patient is not having trigeminal neuralgia. We often get patients with suspected trigeminal neuralgia diagnosed in other centers who come for follow-up treatment in our hospital. And it's very difficult to say whether the patient is actually a neuralgic patient or not, because the oral cavity examination itself shows that there are multiple problems inside the oral cavity, all of which could be contributing to this atypical facial pain. So what would be the common differential diagnosis of a patient with suspected trigeminal neuralgia? Always try to rule out odontogenic causes of facial pain, which is completely under our control. Medical professionals are not very clear about what happens inside the oral cavity, and this is the place where we can really help patients by detecting pulpitis, periodontitis, and other conditions that can cause facial pain. We are also pretty good at diagnosing temporomandibular joint and myofascial pain disorders, which can also be misdiagnosed as trigeminal neuralgia if a careful clinician exam is not done. The less common differential diagnosis for trigeminal neuralgia would be conditions like trigeminal autonomic cephalgia, a condition known as sympathetically mediated pain, which means that the pain is from the sympathetic nerves rather than the trigeminal nerve. And some of the classical examples would be this cluster headache and those associated with autonomic dysfunctions such as conjunctival tearing. You could also have patients with glossopharyngeal or post-herpetic neuralgia. Post-herpetic neuralgia should be easy to diagnose, asking for a history of earlier episodes of herpes. And glossopharyngeal neuralgia generally tends to have its trigger points on swallowing or moving of the tongue rather than on facial expressions, which is what is seen with trigeminal neuralgia. Nervous intermediate neuralgia is another neuralgic condition, but it has its trigger zone in the ear region, and this can be used as a feature to differentiate it from trigeminal neuralgia. Most important to remember is that younger patients are likely to be multiple sclerosis, and it's important that you do not diagnose trigeminal neuralgia in these patients unless they are evaluated by the neurologist and given the clear signal that they do not have multiple sclerosis, which can be quite a debilitating and even a life-threatening disease. So the next questions that I was asked were a series of questions that all touched upon the same topic. What would be the assessment, diagnosis, and treatment of lingual and inferior nerve injuries? What are the indications of microneurosurgery, treatment algorithm for nerve injuries? How do you manage nerve injuries? How do you manage nerve paresthesia? Are there any treatment algorithms? So you can see most questions tend to touch upon the same topic again and again. So before we go on treatment, I'm sure all postgraduate residents would be knowing the basic structure of a nerve. The nerve has an outer layer called the epineurium. It has a covering around the fascicles called the perineurium, and each axonal cell is covered by a separate layer known as the endoneurium. Now, what can cause nerve injuries? Trauma and ablative surgeries can cause iatrogenic nerve injuries. Dental surgeries, implants, and even endodontic chemicals have been known to cause injuries to the trigeminal nerve. Specifically with regard to the lingual nerve and inferior nerve during third molar extraction, this third molar extraction is believed to cause the highest incidence of injury to the trigeminal nerve. Now, Nugent et al., when we say the highest injury of incidence of injury to the trigeminal nerve, it's surprising to see that Nugent et al., who studied 12,000 third molar surgeries in 7,000 patients, observed an IEN damage of only 0.68% and a lingual nerve damage of only 0.15%. So maybe the risks of nerve injury are not as severe as we generally tend to think. They opine that the risk factors generally tend to be age, the type of surgical technique used, and the proximity of the nerve to the tooth. Liang et al. Said that the inferior nerve is at the highest risk during the surgical removal of fully impacted third molars, when there is a division of the nerve by the root, and surprisingly, surgeon experience. When we talk about surgeon experience, we logically expect that nerve injuries are supposed to be more common when surgeries are done by trainee surgeons and not under specialists. Liang et al. Came to an opposite conclusion. They said that when surgeries are done by well-trained or well-experienced surgeons, there's a higher risk of nerve injury. Now, how to explain this illogical conclusion? They gave a reason saying that it is more likely that well-experienced surgeons are likely to take more difficult tooth for extraction in compared to the trainee surgeons, and more the difficult the extraction or the removal of the third molar, more is the risk of injury to the branches of the trigeminal nerve. With regards to the lingual nerve, they said that distangular teeth and the raising of a lingual flap are high risk factors for lingual nerve injury. So, when I am asked, how do you treat nerve injuries? Treatment of any condition begins with prevention. Surgeons must take every effort to prevent the development of a nerve injury rather than spend time and effort in treating a nerve injury. Location of the inferior nerve can be detected by means of an orthopantogram or a CBCT. We are all well aware of Root's classification, in which they have given danger signs predicting high risk of injury to the inferior nerve during surgical removal of third molar. There are also certain classifications that have tried to examine the relationship of the overlap of the inferior nerve over the roots of the third molar, and they have come to the conclusion that it is probably the type 1 and type 2 teeth that probably at a higher risk for the injury to the inferior nerve in compared to the other types of nerve patterns. So prevention, basically prevention of any trigeminal nerve injury would mean you respect hard and soft tissues. Ensure that you have proper nerve protection during surgical drilling. Ensure that your incisions, flaps are placed on the lateral buccal side wherever possible. Don't do blind drilling. Avoid lingual bone removal or lingual retraction. And in cases which have a high risk of definitive nerve injury, consider the use of coronectomy and root retention. The aim of every surgeon should be that he or she produces the least amount of post-trauma and post-operative edema on the neurovascular bundle. Now we come on to nerve injuries and its regeneration. A quick recap of our physiology. You know that when a nerve gets injured, the distal part of the nerve undergoes Wallerian degeneration. The proximal part of the nerve then starts producing axonal sprouting. The Schwann cells from the proximal part put forth what is known as the bands of Bunger, and the axons then move across and result in restoration of the axonal continuity. Another thing most of us are familiar are the classification of nerve injuries, classically given by Seddon, who said there were three divisions: neuropraxic, axonotemesis, and neurotemesis, and a more detailed classification given by Sunderland. Now, which classification is going to be useful to me as the clinician? I believe that it is the Seddon's classification that is more helpful to the clinician, because Seddon's classification mainly concentrates on the time to return to sensation. Neuropraxic injuries should respond within 4 weeks, whereas neurotemesis injury would respond beyond 12 weeks. So if I was a surgeon and my patient had a nerve injury following the surgery, monitoring the patient over a period of 4 to 12 weeks would give me a rough idea whether the patient is having neuropraxia or neurotemesis, so that I can prime the patient on the need for future treatment and the overall prognosis of the nerve injury. Now, what kind of patients do I treat? Generally, nerve injuries can have negative symptoms, that is a decrease in sensation, or what is known as positive symptoms, that is painful symptoms. Basically, in our career, we are going to see three types of patients. First is the patient who is not aware that he has a nerve injury and does not care. The second is going to be a patient who is aware of the nerve injury but does not care. And finally is the patient who is aware of the nerve injury and is worried about the nerve injury. It is this third category of patient that all treatment should be directed to. Can imaging help in treatment of nerve injuries? Neural imaging is still imprecise. There is no neural modality, no imaging modality that can accurately depict the degree of nerve injury that has taken place. X-rays still have a role in allowing you to determine and eliminate the presence of paraneural foreign bodies, such as a plate or a screw, whether there is an impingement of a bone or root on the infraalveolar canal, and whether there is any irregularities of nerve canals or foramen. Literature says that magnetic resonance neurography may have a role to play in the diagnosis and detection of nerve injuries. It is believed to work on the principle of fat suppression, and since nerves have almost no quantity of fat, they tend to be bright on T2 images. And the theory states that magnetic resonance neurography has the ability to differentiate neuropathy due to compression, entrapment, and even non-neural pain, which would help the clinician to make clinical decisions. Coming on to the management. Management would definitely include what is known as the quantitative sensory testing, and more importantly, an objective assessment of the nerve recovery following the medical research council scale. I would advise residents and other colleagues who are interested in this to go and refer to this medical research council scale that helps you in objectively assessing the progress of nerve injury. Now, what is it that is done in this quantitative sensory testing? The first is to detect for the loss of sensation. Next would be to detect neuropathic excess response, that is sensitization. And finally, the overall current level of clinical recovery towards normalcy. Now, what do I need to perform a QST? You do not need any complex armamentarium. You can perform a reasonable QST with cotton buds, cotton fibers, dividers that we have seen in our geometry boxes, what is known as a dual point discriminator. And if you want to be more objective, you can use Van Frey filaments or Semes-Weinstein filaments for this QST. Lastly, you would also need some dental needles and ethyl chloride spray to complete your QST. So what exactly is done in a QST? First, as I said, the QST is going to measure your sensory loss, that is deafferentation. In this, there are three levels of testing. Level A testing is the evaluation of light touch and 2-point discrimination with cotton fibers or Van Frey fibers and the 2-point discriminators. Level B testing tests the response to static and light touch, which can be done with cotton buds. And level C testing is the response of patient to noxious stimuli, that is through heated gutta percha sticks or the ethyl chloride spray. The important thing to remember is that one should proceed to the next level only if there are abnormal findings, or the QST should be stopped at that level. The next part of the QST was detecting neuropathic sensation. You would make a diagnosis of allodynia if a patient had a painful response to level A stimuli. A diagnosis of hyperpathia, meaning that there could be a neuroma formation if the patient has a painful tingling response to level B stimuli. And finally, hyperalgesia, that is excessive pain response to a level C stimuli, or even anesthesia dolorosa, that is pain in an area of sensory loss, would suggest that this patient may be having amputation neuroma. So when we decide to do treatment for a nerve injury, the key variables to consider is, most importantly, whether the injury was an observed or an unobserved one, what is the duration of injury, whether the nerve is located inside the soft tissue or inside the bone, what is the accessibility and feasibility of surgical repair, and finally, what is the response of the patient through the serial QST testing that you have been doing. So a question that immediately comes to mind: a patient has a nerve injury. Do I resort to pharmacology first, or do I resort to surgery first? Now, pharmacological treatment are helpful in counteracting the excitatory effects of acute nerve injuries and involve 4 drugs, mainly corticosteroids, peripheral neural blockades with lidocaine patch, shock-acting anticonvulsant anxiolytics, and analgesics. Gabapentin, amitriptyline, and other drugs are more useful for chronic neuropathies. As regards to vitamin B12, which is commonly prescribed in nerve injuries, its role in acute injuries is a little bit doubtful. Although theoretically, vitamin B12 does help in axonal regeneration, it requires high doses of vitamin B12 and is more useful when injected into the site of, close to the site of the nerve injury, which is not usually possible, especially when you're dealing with inferior nerve injuries, because there is no site where you can inject the vitamin B12. So I am not really sure whether prescribing vitamin B12 in acute nerve injuries actually helps the patients or not. And this is something that should be used, may be more of a placebo rather than having any definitive curative value. Surgical treatment is best indicated in patients in which there is an observed nerve injury, in which X-rays clearly indicate that there are presence of paraneural foreign bodies, and the QST testing shows that the patient has showed no improvement whatsoever in more than 2 months. Naturally, the contraindications would be a patient whom the QST is improving. Patients with unrealistic expectations would demand that the nerve sensation should return back to pre-traumatic levels, and those who have reported to us after excessive time following the original nerve injury, that is more than 12 months. Lastly, you never suggest surgical procedures for a patient who is satisfied with the current levels of nerve function. When do I do the microneurosurgery? Basically, it can be done at 3 times. Immediate is when you actually observe a nerve injury that has taken place. That is, you have seen, for example, the lingual nerve being cut, or the inferior nerve being cut, or the mental nerve being cut. You could take a decision to perform an immediate microneurosurgery at the same time. Often, you may have to resort to what is known as delayed primary, where the microneurosurgery is performed a few days or few weeks later. This could be because of factors such as patient was not fit for a longer duration of surgery, or the site was infected or contaminated, or the patient required further surgical procedures. And lastly, microneurosurgery can be done as a secondary procedure several weeks or months after the initial nerve injury, when the patient is followed up with serial QST testing. So what exactly is done in microneurosurgery? The surgeon, especially in neuropraxic injuries, the most common thing would be to do a decompression, where the overlying fibrotic tissue and scar tissue is released, and a small barrier can be put over the nerve so as to protect it from the adjacent soft tissue. Often, during our maxillofacial trauma patients, if you find that the nerve is rubbing against a particular plate, the mental nerve is rubbing against a plate or a screw, it may be a good idea to put a small portion of a small gel foam or a surgery cell that would act like a barrier and protect it from the repeated micro trauma from the adjacent hardware. The recommended barrier nerve protections I do not think are available in the market in India. After decompression, the next stage would be to perform a resection of the fibrosis and the neuroma under magnification if it is detected, and then to perform what is known as neurography, which is coaptation, that is the joining of the nerves, the proximal and the distal ends. Now, this neurography, the most critical thing that is that it should be tension-free. Sutures can be placed either in the epineural region or in the group fascicular region, and it is dependent upon the size of the fascicles and also I think the skills of the surgeon. Suturing is usually done with a 8-0 or a 9-0 proline. Now, since I said the most important factor was tension-free suturing, if you have gaps greater than 15 millimeters, it is an indication that this require nerve grafts. Earlier, commonly used for autogenous nerve grafts such as sural nerves or greater auricular nerves. Nowadays, literature shows the use of cadaveric nerves and alloplastic nerve guidance conduits. So what are these alloplastic nerve guidance conduits? Basically, they are like a small pipe into which the proximal and distal end of the nerve fibers are sutured to the pipe. And these nerve guidance conduits have neurotropic factors, Schwann cells, and stem cells, all of which help in promoting the axonal regrowth and ensure that there is no abnormal axonal sprouting. So what is defined as success of microneurosurgery? When would a patient be described as a successful treatment of microneurosurgery? By definition, it is a patient who has had a restoration of crude touch and protective senses, and if neuropathic pain was his original complaint, that there should be at least a 50% reduction of the pre-existing pain. Remember, the most critical factor for success of microneurosurgery is the timing of intervention, and studies have shown that microneurosurgery with hypoesthesia conditions generally tend to have a better prognosis than hyperesthesia. Another important thing that is often not given much importance to in our clinical setting is what is known as the sensory re-education, which should be done for 3 times a day for at least 12 months. What this involves is asking the patient to provide tactile stimuli to the non-affected area with the eyes open and the eyes closed, and to perform the same tactile sensation of the affected area, making an effort to remember how the sensation was in the unaffected area. This sounds complicated, but apparently it does help in a significant improvement in patients if done diligently over a period of time. Now, some of the questions asked for algorithms on the management of trigeminal nerve injuries, I was able to find one or two. Basically, it depends. This algorithm depends on what is the nature of the injury. Sharp injuries, that is full transection injuries, that is neurotomesis, can undergo either an immediate repair or what is known as a delayed primary repair. Whereas other types of injuries, that is contusion injuries, traction injuries, usually require delayed repair only after you give sufficient time for spontaneous recovery and you have performed a full evaluation of the nerve function with the QST. Again, surgical procedure would depend upon the length of the nerve defect. Like I told you, here the algorithm says 3 centimeters. I have seen some literature that says that the gaps greater than 15 millimeter itself require some sort of grafting, which can be done by autografts, natural or synthetic conduits, and what is known as neurotization. So neurotization is a procedure in which if you are not able to find the distal portion of the nerve and you find that you are worried that the proximal portion of the nerve would give to abnormal axonal sprouting, resulting in a neuroma. You transfer the proximal portion of the nerve to an adjacent muscle or soft tissue and suture it to that to minimize the chances of axonal resprouting. This was another algorithm that I was able to find on management of nerve injuries following maxillofacial trauma. Again, the critical thing is try to perform the microsurgery if skills and expertise is available at the initial setting wherever possible, or else more importantly, perform serial neurosensory testing for at least 3 months before you decide on taking up the patient for further microneurosurgery. These are some of the books and journals that I had referred for this presentation, and I think the postgraduates would find it interesting to go through these articles and books. Thank you for your patient hearing.
Thank you, sir. Thank you for detailing explaining about the nerve injuries, how to treat it, because it remains a gray area for most of the resident doctors and postgraduates. You have given an insight. So any situations where you have sutured the nerve after detecting an injury, your experiences on that, sir?
So in fact, I was going to end my presentation with that point. You beat me to it. I personally have had no experience with the management of microneurosurgery of nerve injuries. It's probably related to the kind of patients that I get, where generally patients tend to be in the earlier two categories: not aware, not care, or aware and not care. And even if patients who are aware and care, I think in most situations, sensory neuro testing would ensure that patients have some sort of a satisfactory progress. One particular thing I would like to say to postgraduates is there is some literature available on what do you do for nerve injuries that you have detected just before you manage a fracture. A patient comes with hypoesthesia of the infraorbital nerve following zygomatic complex and hypoesthesia of the mental nerve following a fracture of the mandibular parasymphysis or the mandibular dentate portion. Now, literature says that fractures of the nerve injuries associated with the fracture of the mandible tend to heal much better under close reduction, whereas nerve injuries with fractures of the zygomatic complex tend to heal much better with open reduction. This is a little bit tricky because in our clinical career, generally we would tend to operate on mandibular fractures more common and not operate on minimally displaced or undisplaced zygomatic complex fractures. But literature says that if you have a nerve injury with a zygomatic complex fracture, that is more likely to be a permanent nerve injury in comparison to an injury associated with the parasymphysis fracture. So I do not have any practical experience with the microneurosurgery. I am aware of only one surgeon whom I have interacted with who has some experience with microneurosurgery, and he is in the United States. I do not know if anybody from our MaxFac fraternity is performing these procedures on a regular basis in our country.
Thank you, sir. In that sense, the mandible, as you said, maintaining the continuity. Whenever there is a fracture in the mandible, the nerve which is transected remains within the canal. So it heals better by itself. And then in terms of the zygomatic fracture, where the infraorbital nerve gets transected, where it enters into the soft tissue, predominantly, is that we can understand that it is not within a guarded canal, so that the sensation doesn't.
So it also, I would agree with your guarded canal assessment if you are dealing with, say, an ankle or a body fracture. But if you have a fracture running through the mental foramen in a parasymphysis fracture, it's very difficult to tell whether nerve regeneration will happen because you do not know the extent of injury to the mental nerve per se. So if the mental nerve itself has been damaged at the mental foramen or just outside its exit from the mental foramen, prognosis tends to be more guarded in comparison to nerve injuries that have occurred in the angular body region, where, like you correctly mentioned, that there is a canal already present, and this mandibular canal acts like somewhat like a nerve conduit. It's like gives a nice path for the axons to grow and ensure that the axon do not start sprouting in abnormal directions and form a neuroma.
Yes, sir. Thank you, sir. That's all the questions from my side.
James, there are a
Patiently.
few
Yes, sir.
questions in the chat box.
Yes, sir.
If you can take them.
So one of the question is, what is the best imaging modality to visualize nerves? I think that was covered in your presentation, sir, about the MRI.
Magnetic resonance neurography. Again, it's I do not know whether that modality is even available in our country. But the theoretical advantage which I mentioned was that it has the ability to detect neural and non-neural injuries, and whether the nerve injury is because of entrapment or compression, which helps you in making a clinical decision. Obviously, if you see a nerve that is entrapped or compressed, you are more likely to intervene on it surgically, because you know that releasing the pressure is likely to have better outcomes.
Yes, sir. So another question is, there is a lot amount of overlap in pain, especially in diagnosing neuralgia. For example, temporomandibular joint pain. A patient might have migraine, headaches.
Yes.
In those situations, how do we? So, do we need cross reference with our neurophysicians? How do we treat it, sir? It is complex as such?
Yeah. So. I keep telling my residents and I keep telling my medical colleagues that there are 32 reasons for somebody to have facial pain in compared, that is the 32 teeth, in comparison to your 2 eyes or 2 nostrils or 2 ears or the few pairs of sinuses. So I think it's almost mandatory that any patient who comes with unilateral headaches or unilateral facial pain, a dental examination should be a part and parcel of the evaluation. And in many situations, I personally feel that it is an undetected dental condition that is actually resulting in the facial pain condition rather than other situations. If my dental pain, if my dental evaluation turns out to be non-significant, I would then refer the patient to my colleagues in ENT and ophthalmology and ensure that they also give a clear signal that there is no pathology in their respective areas. It is only after that that I would consider referring the patient to a neurophysician. I believe that as a maxillofacial surgeon, it is our responsibility to ensure that there are no undetected odontogenic causes for the facial pain before resorting to medications or surgical procedures directed towards a neuralgic condition. It is quite challenging. Patients often are quite distressed. They have multiple conditions. They have sinusitis, they have NPDS, they have TMJ pains. You will find that their oral hygiene is pretty poor. They have generalized periodontitis, multiple caries teeth. They will often, so it's very, very difficult to exactly pinpoint and say that this is the reason for the facial pain. I generally advise my patients that I will try to rectify the pathological conditions inside your oral cavity and maxillofacial region, but I cannot guarantee that correcting that would address your complaint of facial pain, because you could be having additional factors contributing to the facial pain.
Yes, sir. Thank you, sir. Thank you for your patient answering to all the questions.
Thank you, Dr. Bhagat.
Yes,
You are very
yes.
kind with your words.
Thank you.
Another amazing session that offered extensive explanation by the mentors and a spot-on moderation by Dr. Bhagat. Thank you for your valuable time rendered in imparting your knowledge. The 10th session on infections, osteomyelitis, osteoradionecrosis, and varied surgical modalities is scheduled to take place on 26th of April at 8 p.m. The session will be moderated by Dr. Senthil Kumar and mentored by Dr. Bala Guhan and Matthew Jose. Kindly fill out the feedback form that will be posted in the chat box shortly and participate in 8 out of 11 sessions to get a certificate. Thank you all. Have a good night.
The link is shared in the chat box. Thank you, Dr. Saravanan and Dr. Krishnan and
Thank you,
James.
sir.
Fantastic session.
Thank you very much,
That's
Dr. Jimson
discussion.
and dear team, your entire team.
Oh, we never, the time flew just like that. It's almost 2 hours, 5 minutes.
I'm sorry.
The longest session till now. Thank you both of you, sir.
Thank you, sir. Thank you very
Thanks,
much.
Dr.
James,
Karthik.
thank you, James.
Thank you, sir.
It took a long time to diagnose and then no injuries as well.
Evening show ఆరంభించేది ఇప్పుడు సెకండ్ షో వరకు పోయింది.
Thank God,
Thank you, sir. Thank you.
lockdown has not come to this yet. That's good.
Yeah. Till now, the participants were almost